نجف هستیم. سلام برسونید، ما نجف هستیم، مشرفیم نجف خیلی سلام برسونید. تماس گرفته بودید. خواهش میکنم بله.
No, I will change it, please. I want to record your lecture. Okay.
سلام علیکم. مجدد. سلام علیکم مجدد. سلام علیکم.
حال شما خوبه؟
خواهش میکنم. سلام احوال شما خوبه؟ سلامت هست انشالله. پیشا پیش سال نو شما مبارک. ممنون. سلامت باشی انشالله. خیلی لطف کردی. ممنونم. خدا نگهدار. سلامت باشی. خدا حافظ. قربونت برم. خواهش میکنم. قربونت برم. سلامت باشی. خدا حافظت باشه. انشالله که الهی. آقا فقط پروتئین الو صدا میاد. فقط پروتئین آقا خوشحال شدیم. خدا نگهدار.
Ayatollah Salman, can you start?
Yes.
And also lecture. Thank you. That's my Ayatollah. How many gynaes? Five gynaes. Fortunately, I have a film, fresh film. I didn't see that film. An expert surgeon. She did last week, and appendectomy and ovarian cyst for appendicitis and also ovarian cyst, very big and transport.
Yes, use your PC.
I want to talk about appendicitis first, and then I go to the field and we discuss about the because I didn't edit the film. It's the live operation, live operation. You can see and tell that which part is good, which part isn't, and tell your opinion. About appendicitis, all of you know better than me the appendicitis, what is appendicitis, what is the indication. But I have some PowerPoint I will go very briefly about indication of laparoscopic appendectomy. What is your opinion? How many of you do appendectomy laparoscopically? All of you? Or you? And also, Ayatollah, you don't?
Appendectomy laparoscopy.
You know that appendectomy done less, very sooner than cholecystectomy in 1982, I think, first appendectomy. Why laparoscopic appendectomy is not popular like cholecystectomy?
Emergency surgery.
Emergency surgery. Maybe emergency, or I think that already appendectomy was the minimal invasive surgery because you can do appendectomy by a short incision in the lower abdomen. Incision in lower abdomen is cholecystectomy is in upper abdomen. The difference. But now, when the population become bigger and fat, the laparoscopic appendectomy is very important, and the old surgeon, because now we have a lot of patients with very big abdomen and very fat and has appendicitis in this situation. About indication, clinically suspected or confirmed acute morbidly obese patient. In the past, in the obese patient was contraindication, but now, if, for example, in a hospital that I work, my colleague, he didn't do laparoscopy. He, as a big patient and obese patient, called me, come and there is appendicitis, I want to do laparoscopy for them. Women of childbearing age, pediatric population, and interval appendectomy. It is the indication that has in the book. What about the contraindication? This lack of surgeon experience, this 4 is absolute contraindication. Lack of surgeon experience, inability to tolerate general anesthesia, refractory coagulopathy, and diffuse peritonitis with hemodynamic compromise. About peritonitis, because this question is important. Patient comes with peritonitis and appendicitis. Do laparoscopy?
I try with laparoscopy, but I don't insist in my opinion, and I may convert to open.
Yes. What is your opinion, doctor?
Sorry.
About diffuse peritonitis and appendicitis?
Contraindication.
Laparoscopy or open?
I think still laparoscopy.
Still laparoscopy. Congratulations. I think diffuse peritonitis with hemodynamic compromise, the contraindication. But without hemodynamic, if the experienced surgeon, experienced laparoscopy surgeon, can do by laparoscopy. But intra-abdominal abscess is, in this situation, is more than open. Because interloop, you cannot wash interloop very well, in my opinion. Unless the surgeon should be very experienced and wash all parts. But now, Dr. Bazooki wants to tell that you can go up and you can wash better than. But we speak in the general population, general surgeon, that not in a special center that laparoscopy is very well done, and in the general surgeon, I think if you suspect peritonitis, open your patient. That's doctor and doctor told that.
What peritonitis embed laparoscopy not done? I mean, why?
Why open is better? Because in the open you can wash better than.
You can't wash by laparoscopy.
Especially interloop. There is some paper that intra-abdominal abscess after laparoscopy is more than open. But there is another paper that in the specialized center, specialized laparoscopic center, specialized to laparoscopy is the result of same. Because appendicitis is a very common procedure everywhere. If you tell that if in peritonitis you do laparoscopy, I think it's not good for the general population. If you or Bazooki want to do laparoscopy, I'm agree. But me and other no.
Some situation is very difficult, like cyclolith or big device. The second will not
But extensive previous surgery relative, portal hypertension relative, severe coagulopathy relative, and advanced pregnancy relative. But that's absolute. About surgical anatomy, all of you know better than me. Salam alaikum. How are you? Where are you? Where are you? You told me that you stay in the hospital. We worked together 20 years ago. Together in the hospital.
For 20
20 At that time, I didn't see laparoscopy. At that time. In the Imam Hussein Hospital. Yes. Only gynae had laparoscope in the gynae department. There was two departments, two operation theater. Gynae operation theater is the other part, and we hear that laparoscopy came and we want to go and see the laparoscopy with gynae hand, but we don't have time. And my mentor told that no, it's not good. About surgical anatomy, you know the appendix is a very variation. The appendix has very variation. Maybe in upper abdomen, maybe tip of appendix in the near the gallbladder, maybe retrocecal, retroileal, or malformation of the some part. But the typical and the common is like this: appendix, artery, and ileocecal artery, ileum, and cecum. Yeah. You can, when you go and want to find the appendix, it's better to find the cecum and follow the tenia. Follow in all patients, tenia reach to appendix. Appendix base. All tenia, because there is some tenia, anterior tenia reach to this. We can find it. About position, patient position, and room setup. The patient head is here, monitor, optional monitor, surgeon and assistant in the left side, and always I ask you to put the hand in the side of the patient. Some surgeon, especially gynae, in, for example, in ovarian cyst operation, open the hand and they right here, for example, patient is like this, and they open the hand, and patient, the surgeon stand here, and the hand of patient here. They do operation like this. If you open the hand, you for example, the head is here and foot is here. You can come in this position, and you'll be ergonomic. If your hand is open, you should stand here. And in some cases, because in ovarian cyst also is very important, in hernia, and in the when you operate on the right or left lower quadrant position, it's better to close the hand, and surgeon can stand here or sometimes here. Sometimes surgeon want to change position with the assistant, or in some cases, cameraman should stand here. It's better. Surgeon here and cameraman here. Do you agree with that? If you have any comment or any question or anything, you can tell. Dr. Samson. I told you also.
The running of the laparoscope itself or the monitor itself, where do you refer to it?
Monitor.
Yes.
I think monitor is better to be here. Exactly. If you have, it's better to have one arm to change the monitor side. But if you have only one tower for appendix, I think this is good. Here, head, foot, monitor.
Or a little down.
A little down. In this picture also.
Coaxial alignment. Would you please tell about coaxial alignment? The eyes.
Everybody can come and tell everything.
Ergonomy is very important issue for appendix. For appendix, when the patient is here, it's better to have a wide view. It is abdomen, it is chest wall, and it is legs. The organ is here, the umbilicus is here, and so the best when we make a line between the organ and the camera, it's the best side for surgeon and the best side for monitor. It's the best. Coaxial alignment. All of these should be in the same line. Otherwise, you should do surgery here and look here. Or look here, you do surgery and look here. And your muscles will be exhausted.
leftover.
Leftover. Yes, yes. Leftover, we should stand here, the surgeons here, the camera here, ovary, and camera and monitor here. Coaxial
The
alignment.
position of ovary and appendix is not exactly the same, but in one direction. Ovary or
Uterus is a little.
in this picture is good. Camera, as Bازوki told, about the thoracic position and choice of laparoscopy. Camera port always, I think, better in the umbilicus. In all cases that gynae or except some bariatric and some splenectomy or some special procedure. In the general procedure, umbilicus is the very good place for port placement. And I will tell about the first entry and the access of the, in my opinion, about the access in the next topic, I think. Camera port is here. A 5 mm port in the right upper quadrant and a 10 mm or 5 mm, some different. Maybe 2 5 mm and 1 10. If you put 2 5 mm and 1 10, you should have 5 mm endoscope lens. Because for retrieval of appendix, you need a bigger trocar. Bigger port, yes. This is the variation of the appendix. If you go and see the appendix is not here, you can change your trocar size. Some surgeons put 2 trocar in this line, bikini line. Some surgeon, but it's not ergonomic. But 5 mm port is here, not a very small incision, and I think that's better.
But if we place a suprapubic port, we can't get ergonomic by placing the camera on the left.
Camera here,
No, on the left.
in the left,
Yes, and a suprapubic,
this
we
two.
can't achieve ergonomic.
Camera here,
Yes,
this and this.
instrument and suprapubic.
Yes, maybe this is the alternative
Yeah.
port position. There is in the book,
Mm.
but it's not. This is the exactly ergonomic because your ordinary your appendix is here, camera here, and angle in ergonomy. Your angle should be less than 90 degrees, like this. your hand in open surgery. In how you do open surgery? Here, this direction, no. This, no. This, open surgery. You do. In laparoscopy, also, you should create this angle for yourself. If you want to be happy and don't tire in the good time. That's, alternative port placement and procedure. Identify, mobilize the appendix, mobilize the second if needed, retract the second medially, grasp the appendix with an atraumatic grasper, transect the appendix at its base. It's the opinion of the book, the laparoscopy, last laparoscopy book.
Stages.
Sages, yes. This is the reference from Sages, but different surgeons have different technique and divide the mesoappendix, insert a specimen retrieval bag, examine all staple line, carefully remove all port under direct visualization. But what do you do in appendectomy? Do you use a stapler? Until
no.
now, you use
No, I didn't use
a stapler for appendix.
because it's
You
so
use-
expensive. What we can use, but it's so expensive, so prefer to use similar.
سبورة.
Because stapler is expensive. So trying to find alternatives. Stapler is about $200 in general. But there is a policy for lab-assisted appendectomy. In lab-assisted appendectomy, we modulate our position and our total positions and our procedure. For example, as Mr. Bازوكي drew the line for, that's the patient, and here is the umbilicus. We can put trocar here, just over the appendicular base. After we enter to the umbilicus, here we choose the always 5 millimeter in order to lessen the burden on the patient. We choose 5 millimeter trocar and 5 millimeter lens. It's very, very enough for appendicectomy. We don't have very much vital structures like cholecystectomy for CBD or so. It's appendicectomy, and we are all oriented about its anatomy, nearly. And here the other port from this side. We can use this anterior superior spine and above and medial to it by 1 inch. We can choose this point, or we can choose the suprapubic region, especially in females, for the other port. And the surgeon stands from this side, and the monitor is here. And you see from here. There's a little bit modulation. Why? Because in Al Ghadir Hospital, there is no room to change the laparoscope. So we are satisfied that in the same side for the laparoscope in cholecystectomy, we can choose it also for appendicectomy. So the procedure we do is to dissect the mesentery of the appendix, and the appendix will be alone. We cut the mesentery of the appendix. Here we cut it. By electrocautery. There is no need for harmonic. There is no need for ligature. You just go beside the appendix, proximal to the wall of the appendix. You don't go here. No need to go for the main vessel. We just stick to the wall of the appendix. And then the appendix will be in its minimum diameter. There is no fat with it. And we can retrieve it from this port, which is nearby its base. Then we deflate the patient abdomen. If it is inflated, then it will be away from the base. But we deflate the abdomen, and then we will get the appendix outside the abdomen through a 5 or 10 millimeter port. And by this way, we can continue our procedure by catgut. We will not spend hemolog, we will not spend...
I don't agree. I apologize. I apologize. If you can bring appendix out like this, it's better to do open appendix because patients should be very thin and in the patient, because in indication of appendix, for example, if you want to do operation for me, with a big, I am thinking to find a
I'll comment on your comments.
I agree with you for this. Dr. Kalbasi, my teacher, who started laparoscopic cholecystectomy in Iran in the first. And you know, Dr. No, and is the father of laparoscopy.
Yes,
The patient come to me and told me that I went to Kalbasi. He's the father of laparoscopy in Iran. But his hospital was expensive and I come to you do operation. And I told her that I am the son of laparoscopy.
Can I comment on your comment?
He did a lot of appendectomy. He did like you. He did bicuttary, only bicuttary. Only skeletonized the appendix.
Yes.
It's very easy and very good. I do also sometimes this technique. I prefer this technique also. Skeletonize the appendix. It doesn't need to ligate because if you have appendicitis, the vessel already cluttered. In the appendicitis vessel, especially vessel near the appendix, near the appendix, small, and you can do like cholecystectomy and open, and you have appendix and cecum, which is cecum and appendix, and you can tie this or by liga clips or by hemolac. Hemolac is very good. I have a film. But you can also go and close the vessel. It's a different technique, and everybody can do this by their technique. But if you bring the appendix through distro car and deflate and close it, contamination.
He told me that the obese patient is really difficult. Actually, the obese patient has obesity and the belly away from the anterior superior iliac spine. If you choose just beside the anterior superior iliac spine, it will be thin. You will have thinnest part of the abdomen toward the intraceiling.
This is alternative technique of appendix. No problem. Yes. He did.
And you can do transfixion. For example, if you have intracarpal prior to suture, first there is time consuming to suture from extracarpal point and then to put the knot inside the appendix. It is time consuming. You may be not able to do it, or you don't have a pre-made knot. If you are able to do it, then you can proceed. But if you retrieve the appendix and do transfixion, then you just do it just like the open method. You transfix it, and then when you cut it, you cauterize it or you sterilize it by bovidone iodine. And we irrigate the tract also by bovidone iodine and saline, and then we irrigate the area. We did this several times and succeeded, and there is no infection at the port of delivering appendix.
Just one point.
God is here. God, Imam Zaman is here and help you.
Last lecture is produced by Dr. Jlali. We talked about the remote injury.
especially one of the common sites is the appendix by using of electrocautery. And now you mention the procedure we go to electrocautery. The base of the appendix can be stopped from cautery dissection, right? Is one of the common sites. At the base of the appendix with the secret. Electrocautery should be guided. Yeah, if you use electrocautery with, for example, 80, and you are dissecting the mesentery of the appendix, this can happen. But if you use it 40,
And less time.
This time, yes.
1 second.
yes, and this
Yeah.
time.
1 second. Yes.
This is appendix, this is a meso, this is second. You start from here, cutter, and if you have only this,
Okay.
that's very good.
Yes.
If you have only this, it is true. And after, you start from here to the base. I don't think that is the theoretical. Good example for that I told you, but the UDT. If you separate everything, for example, like this, your second is here, and appendix. Separate everything. If you cutter this side, your currency goes from here and maybe dangerous to this side. But if you attach, no problem. You agree? Yes. Attachment. Thank you. Thank you for your comment. Yes, it's your.
I think LigaSure is everywhere available.
No, LigaSure is expensive. For appendix, because you should open the LigaSure and the instrument. How much is
Everywhere
it?
is a hemorrhage.
Like you should do, surgeon should do appendectomy like an open surgery.
We have
Surgeon should do it
1 or 2 bites because for meso and hemorrhage for veins.
not available and expensive.
Bipolar is okay.
Bipolar is very good. Bipolar is very good.
Between them.
The problem of you, there isn't in the bipolar.
Comment about the indication for
Yes, about indication. Dr. Ayatollah, about indication.
I have only one comment, that we are doing laparoscopic appendicectomy not to minimize the size of the wound or for cosmetic purposes. Actually, we are doing it for 2 main purposes. The first is to reach a better diagnosis. The second is to prevent complications of open surgery like adhesion and hernia formation in the incision. Because I faced a lot of patients who have appendectomy and they have incisional hernia or they have inguinal hernia. So these are the main 2 reasons. And actually, I can give an example, if you excuse me.
Yes.
We had nearly 1 month or more than 1 month ago, a middle-aged man presented to us with typical picture of acute appendicitis. It's typical picture of acute appendicitis. البرادو سكور معلق اليوم ما ادري قد البرادو 15 معلق عابر الالبرادو. We did for him laparoscopic appendicectomy. We saw that the tip of the appendix is inflamed. It's hot, inflamed, and it's about to form a mass. The pelvic colon is adherent to the appendix, the omentum is coming to the area, and we started doing appendicectomy, just like this. But after we did appendicectomy for him, we started to do lavage for the debris and the parent material. And we saw that the pelvic colon is so thick. It is thick, it is not like usual. We thought that this is because of inflammation transmitted from the appendix, but we dig to clarify the picture. We clarify the picture, we remove appendices cloaca from one of its parts. We found a tumor-like mass with perforation of the pelvic colon and abscess formation. It is not done by us.
Abscess neck time.
So, and at that time we should negotiate with the family that this patient is not having only appendectomy, he should have another procedure, like diverting the colon or doing some procedure. We thought of first of tumor, because it was too heavy and it must die. Then we thought about perforated diverticulum.
Yes.
So it was a perforated diverticulum with abscess formation, and the appendix was one of the parts that participate in localizing the inflammation. It was not the appendix inflamed and appendicular mass. It was the perforated diverticulum. So for this patient, if we make the scenario without laparoscopy, if we make the scenario of this patient, we are going to open a gridiron incision. We will retrieve appendix blindly. We will find inflamed appendix. We'll do appendicectomy and terminate the procedure. What we will have next?
Deterioration.
Fecal peritonitis. Then you will think, and the family think, that you did some perforation to the bowel, to the viscera, and you will continue your management without knowing what is there. So this is a very great lesson for us, that appendicectomy is not a luxury thing to be done by laparoscopy. It is a cornerstone in doing laparoscopy for patients with appendicitis. Sorry. So this is a practical example.
Do you have any comments? You? Doctor?
The new research, they said that now appendectomy by laparoscope becomes the gold
The
standard.
standard.
No.
Now the gold
Yes.
standard for
To confirm diagnosis, to see
Other pathology.
Not the gold standard.
they said
Now-
research, yes, will
Yes.
become the gold standard.
Everything changed rapidly.
Yes.
About the wash of appendicitis,
We hope.
they recommend.
But appendicitis is very common, and in this emergency situation, I think if the laparoscopic facility be everywhere, because if you tell that this procedure is gold standard for this disease, you should do laparoscopy, not like gallbladder. Gallbladder is gold standard laparoscopic. Cholecystectomy is laparoscopy. But I don't think so that the gold standard of appendicitis is, or gold standard of hernia repair is laparoscopy. No, it's the same. This, you can do this and you can do this. What is your opinion, Doctor? Gold standard? Is it
For mentioned gold standard, not mentioned in
not gold
text.
standard?
Also for the junior surgeon.
But we prefer to do it.
We prefer, we are laparoscopy, we interested in
We
laparoscopy.
prefer,
But
because of many benefits.
yes, I didn't do open laparoscopy. I didn't remember when and from long term ago I did laparoscopy. But
the golden standard for females, since
in female,
Yes.
in childbearing, in the when you don't know that the appendicitis or other procedure, the indication.
Maybe the story like cholecystectomy.
Yeah.
At first, it's not a gold standard and become a gold standard.
No. In the cholecystectomy in 1987, Dr. Muret start laparoscopic cholecystectomy in the France. Yeah. In 1988, this technique goes to America. And in 1991, after 3 years, explosion of the lavender become gold standard. It's different from the appendix. We should go about, I have experience about the retrieval. If you choose the doctor method, I don't recommend for all surgeons that do this. All surgeons should know the suturing and no, only will stop. Will stop.
No problem.
دم فوری ختم میشه رفت میشه تمام شد finish only not whole azan only remember that yeah what I said if you don't use doctor technique after finishing the operation you should remove the appendix. It's not like the gallbladder. Some surgeons remove gallbladder through umbilical port or epigastric port by and gallbladder as a bag, not put inside the bag. But I recommend you every time you put appendix in a bag, or if the appendix is not very thick and you can put pull appendix in a 10 mm trocar. You under vision pull appendix in the
Use a trocar as a
trocar
sleeve.
and remove the trocar with appendix together. It's very important. I had a case, a very important case, very Ashana, what is it? VIP person, some surgeon come to see the operation and my Professor Dr. Davoi and other surgeon come because she was a young lady, daughter of the other my pathologist, Dr. Hashemi, and we went and do appendectomy very well. And everybody told that this is the best case and this film should be a teaching film. It's very good. And we finished the operation. I told that I wanted 5 mm port. They told that there isn't 5 mm port here.
Lens, 5 mm.
5 mm lens. 5 mm lens. And we don't put the appendix in the appendix not very appendicitis, very complicated appendicitis. Like a normal appendix or early appendicitis. We want to bring the appendix from 5 mm ports. We pull appendix inside the port and the tip of appendix was out the port. And we back and unfortunately after 1 week there was an abscess in the port side. In the VIP.
Yes. We can use
You can use
the gloves.
gloves. Best
One
thing
of
is
the-
gloves or
One
if,
of the fingers.
if we would pull the appendix in the 10 mm port, no problem. But we put 2 5 mm and 1 10 mm. Camera for 10 and 2 5 mm. Everything was done very well and suture and every hemostasis, everything is good.
Maybe.
Some surgeon that this is very good operation. But retrieval is very important for every cases, but in appendix is more important. This slide for I use 1 time this stapler for the appendix. There was cases with a very big fecality here, exactly here, and we couldn't pull the fecality to the cecum or to the appendix. We pull the appendix and cut from here by a stapler. And on that time, we think that there is a polyp or something. But I didn't sure that this is fecality. But after removing the appendix, we open and see that there is a fecality.
I have an experience. Last Arba'in representative of Ayatollah Khamenei in Nirohe Musalleh in military forces came to Iraq for Arba'in, and he had abdominal pain and vomiting, and he was seen by many doctors, and they treated him as gastroenteritis and so on. And he is a very sabur, patient person, and he is ورزشکار a sport person, a sportman, and he came back to Iran. Also at that time I came, but he came after me, and one of my friends that Hajjaba came, and he is very ill and abdominal pain. And I went only, I took a physical examination and examined his abdomen, and it was yes, mass. There was a mass, appendicular mass, and I treated him with antibiotics, and then I did for him interval appendectomy. And unfortunately, here was sloughed and appendicitis. For this case, also I used it. It took about 3 to 4 hours. Dr. Musavi Naini Budu, Abdul Senina, and we used a green stapler. Only I used one time stapler, and if you have in the base slab, I think it's better to do. I put stapler and a little part of secum was stapled and brought up, and I oversew it with the terminal ilum with a fine suture oversew on it.
You can pierce the.
I think one of the best time of stapling is when you have a sloughing of here. It is a little go back, but it was very close to terminal ilum, and I tried not to to close the lumen, but with fine sutures I oversew the staple line with the normal secum and ilum on it with very fine. Alhamdulillah.
And drain, you put the drain also.
No drain. No drain.
Film.
Yes, one
We can go to
drain
film.
for one.
If you have some relative in the stapler company, you can use like this stapler here, stapler mezzo, and everything. We can go to film. Please change to film.
Your laptop is
No. There. There is some other stuff, but I don't think important. For appendix, we should share our.
Complication, bleeding, leakage of appendiceal pus, fecality, complete appendectomy.
No,
Late complication, wound infection, incomplete appendectomy, intra-abdominal abscess, hernia, advantage, improved diagnosis, reduced post-op pain, faster recovery, less wound infection, incisional hernia, adhesion, manage other pathology. Yes, laparoscopy in pregnancy, safe in any trimester, position, insufflation, 10 to 15, any insertion technique can be used, but
in the pregnant woman, you should insert incomplete. If you don't find exactly the base of appendix, you should remain a little. I saw the incomplete, and after some years ago, she did appendectomy, and after that she came with the sign of appendicitis, the open angle.
Otherwise, we should see the confluence of the tinacle line at the base of the cecum.
Yes, in some cases may be complicated, and like cholecystectomy. Do you have incomplete cholecystectomy? I saw several times. Yeah, go to film, because we
Thank you.
have enough time. Film is a little big because we don't edit the film. We bring from hospital, and it's a live operation, like live operation. Yeah. You can tell your opinion, and one experienced surgeon did it last week.
Which more?
The time is 53 more. But appendicitis and
Accept. Hey, yeah, almost an hour. بس light.
umbilical. To report.
10 milli.
Right, 1, 10, another 10 in the left. Because this patient has two pathology, appendix and ovarian cyst.
جماعة النسائية مكان واحد ممكن
يلا.
بينما احنا نسوي بالعكس.
ربك.
نخلط الكيسات وين حتى
endometriosum داره.
Endometriosis.
Did you see the plaque of endometrioma?
بس sit down.
İşi, amca işi. Amca işi. Sen de bilmiyorsun.
هو البوزيشن مالي.
Endometrioma. Right.
You know something about endometriosis in every body.
Is the second tenia is here. Second. What is this? Iliac. Iliac vessel.
And endometrium.
And endometrioma plaque. Yeah.
Endometriosis.
Yeah.
هاي فوق شو اسمه شفته؟
ميزو مندكس.
کدوم داستان؟ خاتمه؟
14/2000. Public, huh? يلا يلا.
هو الكوتري مو شغل. هو السيتنج.
Opening the peritoneum.
Hi, guy. Surgeon.
No, general.
Johnson.
General. يعني هي تلح جوا.
Hello, how are you?
Stop the video. Stop. وقف تعال. وقف الفيديو.
He's interested in doing laparoscopy hysterectomy.
Start.
the appendix from the adhesion, adhesiolysis.
Release of appendix from all adhesion.
Yes.
You should find, I think, good maneuver to release the posterior, anterior,
Yes.
this adhesion.
Adhesion.
What's your opinion about the Grassler?
Type of grasper.
Type of Grassler sheath?
It's automatic grasper.
Not bad.
What is your This is a surgery without edit. Without edit. Isn't one. Yours.
الشيخ حسين. Sir.
You can cutter it, but the surgeon is very patient and very careful, I think.
Results or part from the.
Is there artery inside it? No.
I don't think so.
But she put, I think,
This is grass part. Too much.
For the vessel.
for a small adhesion.
We also can use ligature or whatever.
No.
Possible.
I think ligature is very good instrument for this type of. You can cut all of this by ligature, and but ligature is expensive and not available in every hospital or ligature is available, but the instrument and the handle of ligature. How much is the price of ligature handle here, Christopher?
$600.
$600. You can use for some patients.
There is also reusable ligature handle available.
Ligature is single use, but
We use it many times.
that wasn't artery. That wasn't artery, the adhesion.
The artery bleeding. She's going directly
I think
to the
here,
على البيس وعلى بين.
she's looking.
Maryland is better.
For cauterization.
No,
For dissection.
You should identify the most important things in appendix, identification of the tip, the base of appendix. You should have a good base. Very good maneuver. Very good maneuver. We should create a space because you should put at least 2 hemorrhage. You should create at least space and good distance and good for putting hemorrhage. There is some adhesion here,
Yes.
and I prefer harmonic for this operation. My preference
Harmonic is good dissector.
tool is harmonic. Dr. Bazooki like ligature very much.
Very, very much.
Very much, yes. Ligature. Everywhere ligature. He is rich and have enough money.
This is Hassan. The cameraman is not that good.
Cameraman is not very professional.
What's your opinion about this
This-
dissection?
I don't know. Yes.
لا هذه جاينيكولوجيست بابا على جينيسيس ولا ويب سايتس
Yeah, مو gynecologist. General surgeon.
Not gynae, surgeon.
Surgeon.
She's a surgeon. She's a surgeon.
Female surgeon. Female surgeon.
Male surgeon, yes.
بس يبقى أحسن من
لا والله.
We have one female surgeon. Yeah. Just like
There is a
دكتورة كوثر.
We have 4 fellowship female, and she was the first.
Yeah.
No, the second.
Second.
لا حقيقة
بس الموجودين ده
درس العمل موجودة
موجودة بالقاعة.
إيمان بعدين خلصت؟
مساعدنا أخصائي يعني
إيمان عبد النبي؟
حميدة
اشتغل لابروسكوبي.
عندنا سبب دراسة
إيمان
لابروسكوبي.
هي أصلا أوامر هي
We have 4 female advanced laparoscopy surgeon. Or fellowship. As fellowship. Now I think she create a good space for putting
هيمولوج for the patient.
ايه بس هو الميزة نصف.
size. It is medium. Medium.
Green.
Green, not purple. Purple. Black is very good. In for these cases, black is better.
Black.
Stapler.
No, black.
Black هيمولوج.
Gold. Gold.
Gold hemolog.
The
Gold
biggest one.
hemolog, the biggest one.
Excellent.
Yes, extra large. This cluster is good, but this is atraumatic. You should see both jaw of hemorrhage and clip it. Good. Good. Done. Very well. What is your opinion? Do you cut from here only one hemorrhage?
Sometimes I use, but
I
I don't
think-
have.
I think it's enough.
Pus may come out. Pus may come out from inside the appendix.
No. One for
Hemorrhage.
this part. Not.
I don't have enough experience, and I didn't have any. I have done one case.
Double action. Then there could be a possibility.
Yes, it is blindly and it's not good. And
Lost. Ultimately. Good attempt. But why she is looking for the base before completing the knees? Is there any benefit from this?
What?
She is looking for the base to ligate it before completing the mesocarp.
Before.
Yes, why?
is it possible to increase the
Yes, the speed.
speed? Yes.
Freeze the picture.
Right click.
Play speed. Fast.
First, she want to cut.
Then she decide not.
I think she
بس
cuts.
بس كل سريع.
هاي السريع عملتها بطيئة.
Surgeon is very fast.
Do you agree to cut here?
Yes.
I think no. I think you should remove at least 3 or 5 or 4 millimeter stump. Not exactly. It's not. If you she put another.
She's also a surgeon.
Yes. Definitely.
Because the patient is. I think I don't know. But it's very secure. She put 2 hemolac
Proximal.
2 below and 1 above.
and 1 above. Yes.
One lost it.
This is big stump, sir, or okay.
Appendicitis, very inflamed appendix.
More secure to.
More secure. This stump is more secure. Do you agree?
We should use ligature for this stuff without
Without the clips.
No.
only ligature for
No,
this stuff.
I don't.
Yes.
In the India maybe, but
No,
in other
not
countries.
even.
No. Ligature, only ligature.
No, it's not
It's not
accepted.
scientific.
Not for sealing the
Only for
sealing the
vessel. Only for vessel, not for hollow vessel.
It's a complete collapse. But sir, you didn't answer me. Is there
I will go faster.
No, I will.
There are jump.
I can't jump. I jump.
Yeah.
It's ovarian.
jump شوي?
Now they start to do operation for
Ovary.
ovary. Always, I recommend to put a gauze here. Always, I put a gauze here because yes,
Gauze.
4x4 or a smaller gauze. Yes, inside the abdomen and put it. This is a endometrioma. A very good example for endometrioma and some adhesion.
Separation.
If you put a gauze, don't worry. For in endometrioma, I did a lot of endometrioma. You should remove all internal layer of endometrium. If you remain yes. Good.
She heard you. She heard you on the voice.
They gave this feed, but I didn't have because my computer haven't CD player, and unfortunately I last day I cannot see the film before this thing because only be asleep. Dr. Safa had a special type of torture. He told me that the very important type of torture is the bikhabi. What is the bikhabi?
كن سعيد.
سهر.
يسهر.
Sleep deprivation. Yes. Yeah. You see she opened the this is for guiding.
Pure guide.
Oh, this is the ovary and a very big cyst inside it. Not very big, but 5 centimeters.
Now what's the difference?
5 to 6 centimeters.
لا لا عوف على الصراحة.
على
Anybody want to go for Hamas? Okay.
بس حلوة ما البازوكي.
Those also another benefit of those is to attract of the ovary.
It feels that could damage the ovary.
Could damage, yes. It's better to use by
Yes.
And only
But
cut by scissor.
if you see this film, you are right. He or she is the general surgeon. He is monopolar. Bipolar is very
Better.
You can detach and remove all cysts, traction and counter-traction. It's a very dense adhesion.
Yes.
If you remove all part of intima, interior surface of that,
It has been ruptured.
not ruptured now.
From the
No, the bleeding from the ovary.
This instrument is not good for this maneuver. This is
traumatic.
traumatic, yes. Yeah, very dangerous. Be cautious. Ah. Cameraman is
Very
jumping.
No,
I
I think it is camera
You
woman.
should be there.
Thank you.
You are the best cameraman.
Sure, I think this is camera woman, not cameraman.
No.
Yes.
No. He was cameraman. I know him.
He's joking.
Good quality.
He's joking without putting it.
He is the manager of that hospital. I know.
So he's the best one.
Dr. Mustafa Khomeini.
No. Khatam. If you remove this cyst very well, you done. It's not important if you no problem. You can function this. The material of cyst not problem because it is not cancer. It's the material you can you should remove all cyst wall.
Yes.
Do you agree?
Yes.
This is chocolate. Chocolate.
Yes. Chocolate material, endometrioma. Always in the base there is a very dense adhesion in this. I prefer to clean and after that go. But she go fast and because yeah, it's good maneuver. Remove all part. This is important. This
To prevent recurrence.
prevent recurrence. Yes.
But she is done well.
If small parts remain in the parenchyma of the ovary, we can cauterize it without removal?
Yes, you
You
can
can't.
bipolar.
Bipolar.
Yes.
Just cauterize.
Cauterize but you should remove as much as possible.
Yes.
هي systemic mechanism مو local.
No.
All the baby.
All ovarian tissue remain in place. Yeah? Well, without cautery, only for traction and contraction.
Peeling.
This is the ovarian tissue.
Yes.
Very good. Ovarian tissue remain in place.
You said that you did a lot of cases of endometriosis by laparoscopy.
Here.
But do you think doing endometriosis by laparoscopy is better than open surgery?
For endometriosis, yes. Why? No, it is not good. Manor. I told you.
We should be
I prefer bipolar, but
She's in hurry.
It happens.
only a small part. You remain all because the uterine tissue we should respect ovarian or surgeon. Gynae respect, but surgeon should respect to ovarian tissue. But bipolar is very good.
But endobag.
It's the endobag.
Also, if not available, we can use
You can
gloves.
use the gloves.
Yes.
It's the best endobag. In my hand, gloves. You should create a very good endobag by gloves.
We can also.
If you have a gloves, I show you how we create for some surgeon that experience. This gloves.
extraction technique رو جدا باید بگیم.
You should create a very good video.
This is like this.
نه بزن و قطعی من نگه میدارم شما بزن. بزن.
We talked about this if we have time.
No, no.
It's an endobag. Very good endobag. Cut it, cut the finger, cut the finger.
Your finger.
You need your finger or not?
هذا يعمل هذا.
Dr. Safa cut our head before. Don't need to cut my finger. I recommend to put 2 stitch. Yes, maybe when you So,
Retrieve.
two stitch is better. Is the lateral band.
Transfixation.
Yes, very good. You can put your transfix it. Yes.
Sorry, if the 10 millimeter parts, we can't drive the cyst.
No,
But why? Gentle.
no, you cannot put this material from 10. You should put in the endo bag and after you you should irrigate very well, irrigate some and remove all chocolate material
Because of
inside.
Marsupialization.
Who?
No.
No. For uterine, no. I don't. For
ovary.
For ovary, no. No.
Leave it.
You should eat in place. Every manipulation create more adhesion. You should create, and ovary is a very good organ and repair itself very well.
Sorry, bleeding from the ovary, we can use monopolar.
No, why?
Bipolar. Bleeding side from the for example.
The main operation was appendectomy, and I think she preferred to use bipolar, but
For hemostasis. For losing
for
from
everything, for hemostasis, for hemostasis. You use cautery for hemostasis and cutting also. Yes.
You see, for suctioning, every time she put one or two hole out. Otherwise, the tissue will attach and cannot.
هو الماتيريالز irritant to adhesion cell.
No. Especially in this time, bipolar is very important. This
This is for the bleeding.
This time there is a bleeding, but she used one.
She insists on this.
She used monopolar very well. You know,
Very often.
very cautiously. But monopolar is
Minimum time.
minimal, only touch. No.
Just
But monopolar, bipolar, I really comment bipolar. We put this film to see and tell your opinion and challenge.
Monopolar.
Very good to see folks without
I told the surgeon that Iraqi surgeon will come to you and why you. It's not. You don't recommend this.
Yes.
It's not. But bipolar is very safe and you can use bipolar. But in my opinion, if you have this situation, it is better to put an adrenated gas
Yes.
and catch it for 5 minutes. 5 minutes. Stay and drink tea and stay or sit or find a surgeon, a colleague, Dr. Safa, where is Dr. Safa, and some massage. After 5 minutes, this vessel see.
She have bilateral.
Oh, there is another one.
Nice.
Aye.
Oh, شغال monopolar. Okay.
It's not.
Okay, go on.
She's safe. She's safe. No, only a small cyst, not big cyst. Yes?
Drilling is not recently recommended.
Drilling?
Drilling the cysts for PCO, recently they don't
Or
recommend.
sorry,
Previously we used drilling.
drilling, yes, by who?
PCO.
The
By
persistent
who?
cover.
Yes. But recently textbook does not recommend.
Just use a needle or some anything.
Not
No drilling, no drilling at all.
Drilling, no drilling.
leave.
Although drilling was effective, but recently
Why is it not technology?
I don't know. We were in a session with our colleagues in GYN and they told me no more I think they don't recommend drilling for PCO.
What is this? I think this is a follicular graph. Maybe a graph.
When came out, I think some drilling can
Go a little more.
لا لا ليه سهولة أنت لا بس بتحتى
No,
بس
only a small cyst. She drill it and see that there isn't any chocolate. And I think if you see, there is a mature follicle, not. She think that this is a kiss.
Sorry, sir, but I ask you about the idea behind searching for the pace before completing the mesopen.
Searching.
She go forward for the base before completing the mesopen.
No, she
Technique.
technique.
It's her.
I think this is not bad technique. It's good. First you cut
Also,
this and after, or you can go first and
If it is narrow pace, we can use metal clip.
metal
Metal
for base.
for narrow pace, yes.
For normal bases, I don't use metal clips now.
No secure.
Yeah, I think my if I did this operation, because the base was a very thick in this operation for surgery. I think the suture, intracorporeal suture is better. I put a silk suture because when you put a hemorrhage, maybe crush the inflamed base of appendix. Maybe crush. In this case, don't crush.
If we use intracorporeal, we are facing a problem
Yes.
of needing extra port.
No.
Because no, you will use one for
No
traction.
use. No use. No need extra because you create a window and put a.
So no need for traction.
No retraction. I can use very well this by intracorporeal because intracorporeal is in your hand.
Yes, I
You
know.
can not very tough and not very loose. And I think for this patient intracorporeal suture is better because if you have inflamed base of appendix or in gallbladder, if you have a very inflamed cystic duct, very inflamed cystic duct. If you put clips, may crush the duct, and after you by split. I had in the beginning of my laparoscopy surgery, I think in 2000. I start 2000 or 1 year before that. In the beginning case, I had a case. I put clips in the base of the inflamed gallbladder, and doctor told you have the film and follow your film. And after this patient, at that time I worked in Hamadan, a western city in the Iran. And 5 years I was there, and after that I came to Tehran. In the beginning, of the laparoscopy, I put clips, metal clips. On that time there wasn't hemorrhage. And after one day, the patient was very in a bad situation and the peritonitis. I think that is pancreatitis. I saw the film several times, and I found the problem before operation, before second operation. I crushed the cystic duct. Unfortunately, I lost that film. The film was very important. Unfortunately, I don't know I put where. And I saw several times the film, and I saw that I push and crush the cystic duct. I told my colleague was the surgeon, this case may be pancreatitis. We told the hospital pancreatitis occurred because if we told that we crushed the cystic duct in the beginning of the laparoscopy in the small city, bad situation. And we told that pancreatitis, she has pancreatitis, we go and open the abdomen from xiphoid and we see that the bile is inside it. I told my colleague that there is pancreatitis, very severe pancreatitis. We washed and we went to the site of cystic duct. I removed the cystic duct by my hand and I told my colleague was a surgeon, but I didn't tell him that the problem is this, because I want to know only me. And I removed the clips. I tell him that what happened? Clips, give me a stitch. I put it and put it in the rain and come back tomorrow. Patient was very well because the problem was the sloughing of the cystic duct. Yes. And after some days, I told my colleague doctor, now he is a thoracic surgeon. No, Khorshidi. After some time, I told him that that patient was leakage from the gallbladder, from the cystic duct, not pancreatitis. Because pancreatitis is the patient problem, not my problem. But this is my problem.
Sir, may I ask the stump? I didn't see the surgeon cauterize or put anything over the stump for the mucosa. So it's not recommended in Iran to. We usually cauterize it. Cauterize the mucosa of the appendix. Yes.
No, I don't recommend this. I don't recommend this.
We usually
Not good.
After cutting the cautery.
It's not recommended.
Always I put a little betadine in the tip of appendix.
She didn't either.
No, she didn't. Because I didn't do this operation. My colleague. Yes. I put a gauze or I suction. Sometimes I suction the betadine and go inside and wash. That. Yeah.
Sorry, sir. In the second operation, why you don't use laparoscopy?
On that time,
yes.
Why? No, on that time only we
think about
could remove the gallbladder very cautious. The first cases. On that time we don't teach any. At least 16 years ago. The beginning of the laparoscopy.
Thank you very much.
لا اقول لك محمد انت موجود.
Very good. But interesting, I think.
We learn from our mistake and
Yes.
mistake.
Yes.
Do you think that you always do surface surgery? I don't think you will always.
This is why I put this
Yes.
unedited.
Sometimes we do our mistakes, others learn from us, and sometimes others do and we learn from them.
This is very important.
Yes.
That case was very important. That case came from Tehran to Hamadan. For example, it came from Baghdad to Najaf to operate. That time, in the beginning of laparoscopy in Iran. We started.
I understand your idea behind that, and going from a laparoscope to
لا يجوز اليوم هسه
يعني كل شكل من
ما عندي